So the topic which we will be discussing today uh, is the one which I would say that even whether you are a medical student or you are becoming a consultant, you are working in operation theater, you are working in ward, you are working in emergency, you are working in ICU. You cannot get away from these challenges and these uh, things which we I will be trying to just dissect today. Okay, so usually what we say that vital signs. Just a second. Uh, just a second. There is some problem in my. Okay. Uh, hope- I don't know what's the problem with my. Apologies. Just a second. What has happened? It's not writing. My stylus is not right. Apologies. There is some problem in my stylus. Let me check why it's not working. Right. Okay, I don't know what has happened. I will just try to, the vital signs which we have, one of them is blood pressure. Okay. The other is heart rate. The other is respiratory rate. The other is temperature. Do any one of you know? Do any one of you know that what is the fifth vital sign?
Yes, sir. Same.
Okay. Actually, there is a lot of debate whether this exactly really is the fifth vital sign. But for if you will be discussing with the anesthetist or ICU doctor, they will be immediately saying that pain is the fifth vital sign, even in the people working in the emergency. But still, I was just finding it hard that some of the people were not accepting this, and they were saying that pain is not the fifth vital sign. And actually, there was a claim that pain is not a sign, pain is a symptom. Okay, so yes, we can debate about it, but actually pain is considered to be a fifth vital sign. Okay, so we will just try to dissect from here on. Okay, so whenever we have any patient in the OR, or sorry, in the emergency, what do you think, what can be the causes of decrease in blood pressure? Just think about it, that why the blood pressure will be low. I'm really sorry, I don't know what has happened. My stylus is not working and it has just totally uh, create a big problem for me. Uh, Yes, can anyone please speak out? Just a second.
Sir, there could be a lot of problem starting from cardiovascular. There could be cardiovascular problems, respiratory problems, hematological problem, trauma problems,
Okay.
like in the main sections. And if we go in the further details in cardiovascular, it may be hemorrhage, maybe blood loss, hemorrhage, any cardiovascular
Okay, so actually,
septic.
mainly you can say there are three things. One is the volume, okay. One is the heart pumping, and third is the vessel. Okay, so whatever be the reason of fall in blood pressure, either the heart is not pumping nicely, or either the blood vessels either are dilated too much, or they are leaking the blood, and the third thing is that there is no volume. Okay, so whatever the role. So now, if you know that three problems can be there, or there will be fourth one, is the control mechanism. Okay, if there is any problem in the control mechanism, okay, then still there will be some problem. So now if you can just think some of the causes now, whatever you were telling were actually correlating with what is, if there is any reason heart is not pumping nicely, there will be fall in blood pressure. If there is the blood volume is for some reason the blood volume is lost suddenly, there will be hypotension. Okay, if the control mechanism is not working, like baroreceptor, carotid body, aortic arch, okay, then think about the nervous control. Okay, so for any good reason, if you will just think, if you have the buzzwords of these four things in your mind, you can go and you can further, you can expand from this, that maybe if the heart, what is the problem, there is ischemia, there is overload, there, whatever the reason. Okay, so you can explore from there, but whatever will be, usually the four reason will cover almost all the causes of uh, decrease in blood pressure. Okay, so what you say called as hypotension. Okay, what you say it as hypotension. So like so whatever will be the reason, you will go further, try to see what is the reason. Okay, and before because the low the decrease in blood pressure will cause some signs and some symptoms. Can someone just tell what can be the sign and symptoms if there is decrease in blood pressure? Yes, please.
Sir, if there is a decrease in blood pressure, the body will compensation, and tachycardia will first happen to compensate. Then the symptoms will be maybe patient might be a little bit drowsy or feeling lethargic. Urine output will be less. Uh, uh, Tachycardia, less urine output, or maybe some signs of altered conscious. Uh, these are the main, sir, signs of.
यार लिप्स पे वो पड़े
Can anyone add to it?
कहाँ पड़ी ग्लिसरीन
Can anyone add to it? Yes, I'm sorry. Oh, thanks God. I'm back. I'm really sorry. The whole of my tempo was broken because my the blood pressure of my stylus was gone. So Alhamdulillah, I'm able to resuscitate my uh, stylus. So my stylus will be breathing now. Okay. So in this, the reason was the battery was gone. Okay. So in the stylus, if I don't know how to hold the stylus will not work. If the battery is finished, it will not work. If there is no compatibility, it will not work. Okay. So I apologize for this delay because the whole of my tempo was broken because of it. Okay, so actually the blood pressure, okay, though, so we were, so there will be some sign and symptoms. The like whatever sign and symptom will be, that the body will be trying to either to awake the patient in the way that do something to reattain the blood pressure. Okay, this will be one thing, or the body will be trying to compensate. Okay, this will be second thing. And of course, if you are a healthcare provider, you will try to help. Okay, so now from here we will go on to the management, that even you are in emergency, whether you are in ICU, whether you are in OR. Okay, so what will you do? Any for anything, you should be saying like that, call for help. Number one, whenever, if you have any critical incidents, this should be the approach. I will be telling you the common approach first, and then we will dissect how differential diagnosis and things will go. So number one will be call for help. Okay, any if for example if surgery is going on, you will stop the surgeon for a while. Okay, if for example patient is like is in emergency or any scenario, you will try to clean the sorry make sure the scene is safe. Okay, or you will bring the patient to a place of safety. This is one thing you will be doing. Okay. And then call for, as I told you, then any probable apparent cause, like for example, if patient is receiving any medication which can decrease the blood pressure, you will immediately stop. So always remember this word stop. You will be stopping something in any emergency. For example, if you are giving epidural, okay, and the epidural infusion is going too fast and there is hypotension, you will stop the infusion. So don't remember the word stop. Okay. Call for help means call for extra pair of hands, senior help, whatever it can be. So help means help. Okay. Stop, and then you will say resuscitation. You can use this word whether you are a medical student, whether you are going for any other exam. Resuscitation, management, okay, and evaluation. These three things will go side by side. So this word is not only for medical students. This word is for any of the exam candidate. The word will be the same which I have used. Okay. So resuscitation, evaluation, and management will go side by side. You will be the basic approach for managing any complication is A, B, C. Isn't this funny that even in medical college, as a doctor is using this word ABC? So A means airway. Okay, so Heather, can you just quickly tell what do you mean by airway? What you will be doing in airway? Okay, okay, if it's not available, I will try to explain. Airway means you have to make sure.
Oxygenation.
Sorry, no,
Maintain
no,
oxygenation of patient.
no. Yeah, clear your concept. Airway clear means airway clear. Okay, so you have to make sure the airway is patent. So for that, what things you can do? You can make the patient prop up. You can do the head lift, chin tilt. Sorry, head lift, chin tilt, head.
Head tilt is chin lift.
Yes,
Yes.
sorry, I'm using the wrong head.
Head
Head
tilt and chin lift.
head tilt, chin lift. Okay, then you will even in emergency use this word C and E. Okay, C is for compression
E is
and
for
E is for
elevation.
elevation. Okay, this is for holding the mask. Okay, so whatever you might need not to explain each and everything about it, but whenever you are using this word, it means that if your airway is not cleared by these things, you will go further up. I will be telling in only one way, and then we will only tell ABC. Okay, so I'm explaining what possible ABC you can do. Then other thing, you can add on suction. Okay, if for example any foreign body, so your protocol will be towards foreign body if there is obvious history or something like that, but usually suction, foreign body, then at the same time one thing will come here which is not a part of it, but you have to, maybe you can say that you will make sure this thing at even at the start conscious level. Okay, so because if conscious level is deteriorated and patient is not conscious, that maybe you will be adding something for this thing. Okay, so at the same time, if the conscious level is not there, so maybe you can protect the airway. Okay, protect the airway by simple, you can say that like you will be putting LMA, laryngeal mask airway. Okay, if any of the medical student, because today maybe some of the are the medical students, so I'm just trying to take all of you together, but it's a very simple thing and it's for everyone. Okay, it's for everyone. So or endotracheal tube. Okay, so LMA or supraglottic airway devices means anything above the glottis, anything above the vocal cord is supraglottic airway device. Okay, so you should be knowing that you will be protecting the airway either by just head lift, chin lift, just suctioning and this and that, and if conscious level the patient is not maintaining the conscious level, you will be maintaining the airway. Okay, so this will be A. Then like anything which we can do with the airway. Anything else? I think these are the things which are coming in the airway prop up. You will make sure the airway is clear. Then the second thing is breathing. Okay. Of course, you will, if the patient is not able to, because there will be some things will be going together. Initially, you are only looking at the vital signs, but in practical conduct of patient care, some things will be going as a background. One thing will be SpO2. Okay. One thing will be ECG. Okay. There will be some people who will be maintaining the IV lines, and they will be adding on to all these things. But I'm, for conceptual purpose, I'm just trying to tell what you have to do for airway, what you have to do for breathing. Okay. For breathing, maybe you are attaching with face mask, or you are attaching with the nasal cannula. Okay. Or next step will be, there is a face mask with reservoir bag. Okay. Reservoir bag is as the name is telling, there will be something which is increasing the what you say, uh, this one, oxygen percentage in the air. There is 21% of oxygen. Okay. And maximum by nasal cannula you can give around 40%. Maximum, I'm making it simple, you will find it differently, but I'm just telling you a practical simple thing. According to the flow, you will find different percentages, but around 40% with the nasal cannula, around 50% with the simple face mask. And then, as the reservoir bag is telling, so there is one thing which will be increasing the oxygen concentration in the air. This is 21%. We want to increase it, increase the fraction of oxygen being given. Okay. So reservoir bag are of two kinds. One with non-rebreathing valve. Non-rebreathing valve. So the purpose is that if there is a mechanism, there is a like this mask is like that, the mask is like that, the oxygen is coming like this, and there is a bag here. So if non-rebreathing means when the patient is inhaling, there is a mechanism, there is a valve here, there is a door here which is opening, okay, and giving 100% oxygen going from this part to this part. Okay. While if there is not this non-rebreathing valve, then there is some oxygen coming here, some carbon dioxide coming here, so there is mixing of gas. So actually, practically when we use it, we always have this with non-rebreathing valve. But this is also that maybe some people can ask you in detail. So whenever you are using this word face mask with reservoir bag having non-rebreathing valve. Okay. So I hope your concept is clear now. So this will be increasing the fraction that like oxygen is coming from this way, going inside, and there is, when the patient is inhaling, only 100% oxygen is going through this part. Okay. And there are, if you see the mask, there are some holes here. So when the patient the expiration is going through this direction, it is not coming to this direction. Okay. When we expire, there is CO2. Okay. So this is the concept. Next step, if the patient is not able to have proper breathing, then the next step is that either we ventilate the patient non-invasively. This is what is called as CPAP or BiPAP. Okay. Uh, Bi-level positive airway pressure, constant or continuous positive airway pressure. Okay. You might have heard about this thing, that there is a device which is giving oxygen via pressure. Okay. So it is for that to work, the patient conscious level should be there. So it is just helping out. Okay. It means that you want the hand to go up to your above the head. With your effort, you are bringing the hand towards the shoulders. Okay. And now someone is helping you to raise it above head. Okay. I repeat, like you are able to move the hand from the bed, you are lifting it up to your shoulders, and now someone is helping you to take it above your head. This is the concept of non-invasive ventilation. Okay. And bi-level means for inspiration you need more pressure, so that is called IPAP, inspiratory positive airway pressure. And for expiration you need relatively less pressure, so that the patient is able to expire. So usually there is a difference of 4 usually. Okay. So this is the concept of non-invasive ventilation. Okay.
ايوه
Please, can you mute your mic? Okay. So in recent past, in the COVID time, there was something extra which was coming, was high flow nasal cannula. I am not prepared for this topic today, and actually this will need more time. So maybe we will try to do it at some other point. But just to filling the gap, I'm telling you the high flow nasal cannula, it is providing oxygenated humidified oxygen at a high flow, which is helping out the breathing and oxygenation. So this is the concept of high flow nasal cannula, high flow nasal oxygenation. Okay. So if this is failing, then we have to put the airway. Airway maybe. I what I was forgetting in airway was oropharyngeal airway and nasopharyngeal airway. I was just uh, thinking that I am missing something. So one thing is called as oropharyngeal airway. Okay, oropharyngeal airway is the one which you open the mouth and you are putting inside, this is to lift the tongue, which is compressing the airway. Okay, or there is a nasopharyngeal airway which is passing through the nasal. You just lubricate the nasal cavity and you put a silicone soft material which is passing through the nasal orifice, and it is opening the nasal like airway. Okay, so when we were talking about airway, the thing which I missed was this oropharyngeal or nasopharyngeal airway. There is another similar device which is called as COPA, cuff oropharyngeal airway. Okay, this is for specialized anesthesia people or ICU people. This knowledge should be there. You can read about it. Cuffed oropharyngeal airway. This the basic mechanism is the same. Okay. So now the next step, the next step will be in the breathing will be that patient is not able to breathe at himself, so that we need to ventilate the patient. Okay. So now we have to intubate the patient through endotracheal tube or put a supraglottic airway device, and now there is a ventilator. Okay. So before ventilator, there is something else which is called as ambu bag. Okay. So ambu bag is the one which has one-way valve and it is giving the ventilation manually by the hand. Okay. So either you will be doing the ventilation through ambu bag or you will put the patient onto ventilator. Okay. So this is the basic concept about what is airway and breathing. When now any complication occurs and you will be saying that your approach will be airway breathing, and now the third thing will be the circulation. We will just elaborate what do you mean by circulation in coming in few minutes. Okay. So but this is the whole concept. I'm giving you a concept which is there by any medical profession working either in ICU, anesthesia, or the principle will be the same. In the ICU, the patient may be already intubated. Okay, so in that case, if the patient is taking 21% oxygen, maybe you will increase to 100%. Okay, this will be one thing. And how to check the airway now? You will take it on manual and you will try to ventilate the patient, whether the air is going bilateral equal. This will be the thing. Or maybe you will change the ventilator setting if you will make sure the patient is ventilating well, or this, because this is a big topic. I'm just giving you a concept. What will you be doing? Okay, so maybe the scenario will be different, but the concept will remain the same. Airways should be clear by any way, either spontaneously or by some way. Breathing, patient should be breathing or either spontaneously or by some help. Okay, so now come the circulation. So for circulation, you will be checking the blood pressure. Blood pressure is one of them. Heart rate. Okay, then you will get the help of associated thing. Some all will be the clinical parameters and some of them will be the monitoring parameters. Okay, so the clinical parameters, because the result of blood pressure is circulation. Okay, so you will be looking at the signs or symptoms of circulation. Okay, so that it will include, what will be including the skin. Okay, the mucous membranes. Okay, whenever you are feeling dry, whenever you are feeling thirsty, when you are dehydrated, your tongue will be dry, your eyes will be sunken eyes. Okay, sunken eyes. So these all will be the signs and symptom of poor circulation. Okay. And there is another thing what is called as capillary refill. Capillary refill. So like, and of course, everything will be affecting the conscious level. Patient is not having good circulation, patient may become irritable. Okay. So these are the journal signs and symptoms. That the skin touch, maybe if the circulation is not good, patient will be cold, clammy. Okay. Cold, clammy, sunken eyes, dry mucosa, and the patient will be looking dry. Okay. So, and in babies, there is extra thing which is fontanelle. The fontanelle will be depressed. So this thing will be extra, which will not be there in the adults. And in adults, we don't have fontanelle. Yes, unfortunately, maybe there are people we don't keep their head cool and not using the head in the proper way, but that is an exception. So fontanelle. So now what you will be your will be action. Your action will be of course, as I told you, the other thing which will be helping as a monitoring will be ECG, will be one thing. Okay. ECG on the monitor, there is a monitor which will be telling you a constant, or there will be a monitor on the monitor screen, and the other thing will be the 12 lead ECG. Okay. So as an initial tool, you will just have reliance on the monitor, but actually in majority of cases you will be going towards the 12 lead ECG print. Okay. Because anything will be, because now coming back, if there is any problem with the heart, you will be able to pick it out. Okay. If the blood volume is not good or circulation is not good, it means that you need to give some fluid. If the central control is shut down, there will be some changes in conscious level. Okay. Like for example, patient having a stroke can have low blood pressure. Okay. So because we started our discussion with the vital signs, the blood pressure, I'm on only opening the discussion, and maybe because today it will not be finishing, I will continue to tomorrow. But the person who does not attend today may be having some problem to continue the discussion tomorrow. I will request all of you, whosoever attend, do continue, because this is the message. If you understand, you will be a very good physician who will be able to pick out any problem in the patient, because this systematic approach, maybe you will see lacking even in you can say very senior people. Okay. Maybe very senior people who are big consultants, even sometimes they don't have this approach. And like you, some when we started, someone was saying oxygenation. So oxygenation is not airway. Okay. Airway will lead to good oxygenation, breathing will lead to good oxygenation, but oxygenation is separate than airway. Okay. So that is the purpose which I was telling you. Now what will you be doing as a support? You will make sure how is the circulation, then you will maintain the IV cannula. Okay. So for IV cannula, there will be a lot of problems which you can face. Okay. The veins are collapsed, patient is, you are not able to maintain the IV lines. So this message is for not only for the people practically working in different places, and also for a house job student, house jobian, new house job student, or even medical student who wants to develop their skill. There are certain ways to increase the chances. You can have the proper position. Okay. You can have like postural change in a way. Okay. That there is pooling of blood in that area. Okay. Like if you are taking the cannula in the hand, you can bring the hand falling down from the bed for few seconds, so that there will be some pooling of blood there. Then you will put a tourniquet. Okay. Tourniquet. And then you will feel the veins. There should be proper lighting. Okay. There should be proper lighting in that place. Okay. And the biggest way will be that you should not panic, because if you are if your hands himself are trembling, you are not focusing, you will not you will be pricking blindly and you will not get it. So take your time to achieve this end. So position, tourniquet. Then if still you are not able to do it, there are certain things which can help. One of them is ultrasound, one of them is vein visualizer. I will request all the even the juniors to have a look just these buzzwords, right? How ultrasound help for IV cannulation. How vein visualization, vein visualizer help in IV cannulation. You will find all the videos in the YouTube. Okay. Then what else? If even this is not helping, what else you can do is there is what is called as one of them is intraosseous line going towards central line, because central lines are usually big. Okay, so you can use ultrasound either to take peripheral lines, or you can go towards central line. What else you can do? Intraosseous line, as I told you, intraosseous line is to enter in the bone. Okay, there is a whole topic of intraosseous line. Of course, we cannot cover this, but you can. I'm telling you the word. Please explore them. Intraosseous line, central line, and then what else? The last resort is surgical section. Okay, and here I will also tell another thing which is also make the discussion complete. There is in big hospitals there is an IV team with all these expert people who the ward is filling. There will be a special number. Round the clock, there will be a dedicated team who are supposed to do IV cannulations in the hospital. Usually, Miskin anesthetist is the one who is leading this team as well. That in the whole of the hospital, if they are not able to pass IV line, they will call anesthetist. Okay, but there is a dedicated team with all the gadgets who are going there to have the IV team. So the bottom line, because I'm trying to drag everyone with me. So even if you are in emergency, working there as a house officer, and in turn you can say, and now you face these problems, so you should have these things in your mind: intraosseous line, ultrasound, vein visualizer, central line, surgical venesection, IV team. Okay. So this is the whole of the thing. Similarly, as I mentioned for airway, also there is a difficult airway team. Okay, so you can tell in the exam. For this message is for the people who are going for the postgraduate exam, the difficult airway team, they can ask. The difficult airway team is also a dedicated team who is going for any difficult airway management. Okay, of course this is not available in everywhere in Pakistan, but at least you should know that the different teams, how their role is. Another team, now I'm telling the teams as well. Okay, the teams which will be helping to achieve these ABC. Okay, there is another team which is called as rapid response team. Okay, what is rapid response team? As on vital signs, they work on a early warning scores. Okay, so the rapid response team means any patient anywhere in the ward, anywhere in the hospital, getting change in their vital signs, the nurse will activate the rapid response team. Okay, RRT, there will be in the big hospitals, like I am working, there is always a call RRT ward, this. Okay, so this is rapid response team. Similarly, if there is a cardiac arrest, so there is another team which is called as code blue team. And by the way, this question may be any of the team, because I have done a dedicated discussion on different various team in hospital. So you can I will share the link for the people who are interested. I have discussed all the teams, but this is not a big science. It's very simple. Okay, I'm just correlating up till now whatever discussion we have done for managing the complication. You need to know what's going on. Okay, and what help you can get from different teams. So code blue team is the one who is doing the CPR. Okay, what we called as basic life support and the advanced cardiac life support. And the third thing which is there is pediatric advanced life support. Okay, so the people who ask me what to do when they are in house job, or when those, so these are the things which you should be doing: BLS, ACLS, PLS. There is another advanced thing for the neonates, the youngest of the adults. Okay, youngest of the adults, that neonate, the babies. So there is another specialized thing which is doing the NRP. This is called as neonatal resuscitation program. So this is also, I'm telling that these terminologies, if you are aware, if on a lighter note, if in Munna Bhai MBBS in first year they can teach anti-tuberculous drug rifampicin and isoniazid, so I think even whatever year you are in, you should be knowing these things. Okay, so I'm just trying to give you a different concept that one you will find in the books. Okay, so up till now I hope you are getting the point. Early warning scores, please, buzzwords. You can see if any one of you after this discussion wants to contact me, you are welcome. If you are not finding, I will help you out. So early warning scores, there are two concepts. One is that Pews, one is called as Pews. Dr. Zoya, if you can close your camera. Your camera is, I think, you're open. If you can just close your camera, please. Okay. Uh, I'm sorry. So early morning score, one is Pews, but Pews is called as pediatric early warning scores, and they categorize separately as Mews, which is maternal early warning scores. These are all detailed, but the concept is that any change in the, okay. So up till now, I hope you are with me. Airway, breathing, circulation. Okay. So the special monitoring which we can do, one of them is the simple blood pressure. Okay, and there is what is called as non-invasive blood pressure. The thing which will be new for junior people is invasive blood pressure. Okay, so invasive blood pressure, but how we will do, there is an arterial line. Okay, arterial line which the people will taking, and we will take checking the pulse, and we will directly putting a line inside the artery. Okay, an artery, that line will be attached to a transducer. Okay, and that transducer will be giving like this. Okay, beat by beat blood pressure will be coming. Okay, so that will be telling the exact, because if you are taking with non-invasive blood pressure, the reading will not be, maybe not be reliable. Okay, and the not exactly accurate in cases the patient is having very low blood pressure. Okay, so if you are take in any scenario anywhere, like where you want to meticulously monitor the patient, you need to have arterial line. Okay, so the extra information for the people going for candidate, the exam candidate, you should be knowing what information you can get from this arterial waveform. Okay, so you can get about SVR, you can get about contractility, how the heart is contracting. Okay, how is the SVR, and how is the blood volume. Okay, so volume status, SVR, and contractility, all three information you can get with the waveform. Of course, we don't have the time to tell, I don't have time to explain in detail, but this is a tip of iceberg. You can go in detail. So arterial blood pressure monitoring, you should be knowing, whosoever is doing it. So you should be knowing what information you can get from the arterial blood pressure. Okay, so this is another thing. And then of course, ECG, again, a big topic. I have discussed actually ECG in details. All of you can have a look. But ECG will tell you about arrhythmias. What else? Electrolyte imbalance. Okay. Which electrolyte imbalance can hypotension? Anyone, please, just to see whether you are awake. Which one electrolyte imbalance can cause hypotension? SVR is systemic vascular resistance. Okay. Just a second. I don't know. Calcium, potassium. What about sodium? Okay. Low sodium will. Okay, low sodium can cause hypotension. Of course, all these can cause. But if someone is asking you the first thing which come in the mind is sodium, because low sodium will. The sodium is the one which is maintaining the blood volume. Calcium and potassium, yes, it will cause. It will cause in a. You can say they are the traitors. Okay, if sodium is the, you can say, the main one. The calcium and potassium will affect the heart. Okay, calcium and potassium will kill the heart. Potassium and calcium will kill the heart if they are not in proper order. There's like potassium, like you can say, cells are the bags of potassium. Okay, so in any condition, if potassium is going crazy, the heart will go crazy. In heart will go crazy, the blood pressure will go crazy. Okay, so you can get some electrolyte imbalance, and then of course ischemia, okay, infarction, and of course some chronic things like hypertrophies. Okay, hypertrophies you can get in arrhythmias. The arrhythmia can be tachyarrhythmias, bradyarrhythmias. Okay, so any arrhythmia can cause hypotension, because our party started from hypotension. So I'm just trying to bring you back in the memory, because I go in too much details. So I'm just bringing you back to the topic of hypotension. So anything can cause hypotension. So one of them will be arrhythmia, whether there is atrial fibrillation or there is even heart block, first degree heart block, second degree heart block, third degree heart block. Okay, which will be visible in the form of changes in PR interval. Okay, PR interval is with reference to heart blocks. The uh, of course, there are some other heart blocks as well, left bundle branch block and right bundle branch block. But the main, whenever we say heart blocks, it means the PR interval changes. Okay, and then if there is a sequence of this P wave, QRS complex, and T wave is not there, okay, this is what is called as arrhythmia. So maybe one of them will be atrial fibrillation. If it is like an army showing a very beautiful wave, but they are not creating the result, this is atrial flutter. And if it is a terrible one, it is a VFib, or if there is another VTAC. Okay, so VTAC usually is with some rhythm. A VFib will have no rhythm. AFib will have no rhythm. Atrial flutter looks beautiful, but it is almost the same. Okay, VFib is near the heavens. VTech can go to the heavens and come back. So I'm just telling you what emergency arrhythmia, because all this is ACLS. All this which I have told you, tachyarrhythmia, bradyarrhythmia. Now bradyarrhythmias is one of them is heart blocks. Okay, one of them is heart blocks. But of course, there may be any other reason of bradycardia. Bradycardia can cause, again coming back to from where we started, whenever we want to check a blood pressure, there will be heart. So heart will be in the form of contractility, because in the form of rate and contractility. So whatever is disturbing the rate and contractility can cause problem. If the contractility will be decreased, the result will be the cardiac output will not be maintained. The stroke volume will not be maintained. Okay. So these are friends. If you don't understand the whole of the theory, unfortunately, you will not be able to treat the hypotension. Okay. So whole our discussion from wherever we are going, right, left, up, down, our aim is the same. So this information we can get from ECG. I told you about blood pressure. There are so much details about blood pressure as well, but mainly non-invasive and invasive. Important thing for non-invasive blood pressure is the size of cuff. Okay, so there is appropriate size cuff which should be there, covering the 2/3 of the length of the arm and the circumference of the arm in a proper way. If the size of cuff is not good, the blood pressure will not come. Okay, so this is very important, especially maybe if you have put a big size cuff in a small arm, and if you have put a small size cuff in a giant obese patient, so the blood pressure, whatever it's coming, it will not be reliable. Okay, so again, the details of the simple, if you remember, auscultatory method, oscillatory method, palpatory method of all the blood pressure. And by the way, they can ask even this question. I have answered this question in fellowship exam of Ireland. What are different ways of measuring the blood pressures? So I never forget. So never take easy anything. Okay. So whether you are a medical student of first year or you are going for a specialized fellowship exam, this blood pressure will never let you breathe. Okay. Because this is the basis of medical science. This is the basic basis of being a doctor. Okay. So let's revise up till now. We started the discussion about hypotension. We discussed about the basic problems, the blood pressure, the how to manage the airway, how to see the breathing, how to see the circulation, and then the rest of the things will come. Okay, so today I will be focusing on these things. Up till now, anyone wants to ask any question? Any question up till now? Okay, because this is a tip of iceberg. You can explore from here. You can explore your discussion from here on. You can go, as I told you, each and every step has a big, yeah, you can say these all points are tip of iceberg. Let's, like we say, sodium. So what else will be controlling the sodium is aldosterone. Okay, so your mind should be exercising in a way. What are the problems related to aldosterone? So if there is no aldosterone or there is low aldosterone, there may be a lot of causes for low aldosterone, okay, or low function of aldosterone, because so that will be with reference to, for example, anything related to adrenals, okay, anything related to adrenals. Then another thing which is controlling sodium concentration is ADH, antidiuretic hormone. So antidiuretic hormone is related to pituitary, and pituitary is under control of the grandfather hypothalamus. So you should be knowing the same physiology which you will be studying in first year of MBBS. If you don't have good grip on that, unfortunately, our dear of old ducks who are not able to understand, they are not recalling their first year MBBS. So message to do medical students: if you are able to correlate all these things, only then you can, because when you will become a doctor working in emergency, ICU, anesthetists, whatever you are, if you don't know the correlation between all these things, and whenever the word hypotension is coming, if you miss any of these things, you maybe in 99 times you are able to treat the patient, but no, maybe you will lose patient one day. Okay, so this is the main concept you should be thinking. What is the gentleman ADH is doing? So ADH is controlled by the hypothalamus and the pituitary. And if any problem there, either it is neurogenic problem, okay, or the nephrogenic problem, the kidneys, they are not responding to ADH. So it will be nephrogenic problem. Okay. So the result will be either syndrome of inappropriate ADH or diabetes insipidus. Okay. So I'm just telling you the tip of iceberg, and then you can go in details, and because these questions they can ask you in different ways, but you should be knowing another problem the with reference to head injury is cerebral salt wasting syndrome. So this is also one of them. So you should be knowing the basic problems with reference to sodium. I have only explored the sodium, gentlemen. Okay, then any problems with reference to potassium, they will affect not the volume, they will affect the heart. Okay, the contractility will go. So whenever there is any problem with reference to potassium, you should be knowing what are the ECG changes in hyperkalemia and hypokalemia. Okay, and with the reason, and the reason will be coming from the action potential. So if you don't remember how the action potential in the heart works, unfortunately, you will not be understanding why hyperkalemia is causing this thing and why hypokalemia is causing this thing. So now you will hurt your brain, ratta, cramming. Okay. So if you want to do, if you don't want to torture yourself, please revise your action potential of heart. Believe me, it will give you such a beautiful concept later from there on, that you will be able to understand why hyperkalemia is causing this problem, why hypokalemia is causing this problem. Okay, so hyper and hypokalemia with reference to, if you want to understand, should be knowing what is the action potential of heart. If you know the action potential of the heart and each and every step, what is happening and what is the role of potassium, then you will never forget the changes occurring in hyperkalemia or hypokalemia and what's the problem. Usually you will be replacing potassium if there is hypokalemia, and you don't replace it too fast. Okay, you will not replace it too fast, you have to replace it very slowly. Okay, usually 10 milliequivalent per hour, 20 milliequivalent per hour, like that. Okay, so this is another topic of detail how you replace it, but usually for hypokalemia and hyperkalemia, a little detail, I will tell you a few words about it. We are also dealing with the complication at the same way. Okay, for hyperkalemia, we will do how that potassium, we can control potassium. And believe me, this is the question which can be asked in FCPS exam, MCPS exam, medical student, emergency medicine, whatever you are. potassium management can be there. Okay. So we will be looking at three things. One will be the sources, okay, from where this gentleman is coming, other than bananas. If the people are taking a lot of banana, there will be a lot of potassium in the body. But don't worry, even if you eat millions of bananas, bodies can control the potassium. So source is not only problem, but of course, oral source or IV source. So whenever you want to control hyperkalemia, you will have to control these sources. So either you will stop potassium containing fluids, like for example, linga lactate or any potassium containing fluid, you will stop, or oral, you will try to stop it. And now the second thing will be absorption. Oral absorption you can stop. There is something which is called as K-exilate. Okay, so K-exilate is the one who will hug potassium and not let it absorb. So potassium exilate is the chelating agent for potassium, who will not let the potassium being absorbed through the gut. Okay, and then next point of interest should be for you that from where potassium is absorbed. So it is the small intestine, I think duodenum or ileum, I don't remember exactly, but you should be knowing very exactly if you want to be, if you are, I don't have to appear in the exam tomorrow, so I can forget, but you cannot forget. Okay, but actually you should be knowing from where potassium is absorbing. So potassium K-exilate is one of them. Okay, ringer lactate, and now we will go to the other thing, is what is called as transcompartmental shift. Transcompartmental shift. So this is the most important usually, because I told you that potassium is full, the cells are bags of potassium. So at any point of time, you can kick their bags to go in the cell. So now you can go back to how the cell membrane works, and usually sodium potassium ATPase. So usually you can just recall that any beta 2 agonist will push the potassium in the cell, kick inside the cell. This will be one. So you can nebulize with salbutamol. Okay, this will be kicking the potassium in the cell. Then the gentleman insulin. Okay, insulin will push the potassium in the cell. All the ions actually, they also bring glucose into the cell, and so potassium is also one of them. But whenever you will be giving insulin, if you mashallah, very good, you correct the potassium, patient died of hypoglycemia. So don't forget to give some dextrose water. So you will be giving 10% or 25% according, sorry, 25% or 50% according to the availability, dextrose water. Okay, so whenever you are giving insulin to decrease potassium, you have to give dextrose water. Okay, this is for intercompartmental shift. These two things. Now, potassium and hydrogen are friends, so you have to create enmity between them. Okay, so you have to bring them away, get lost. So what you will be doing? You will be trying to decrease them by giving bicarb, sodium bicarb. So this will treat acidosis, because hyperkalemia and acidosis are friends. So whenever there is hyperkalemia, there is acidosis. Whenever there is acidosis, there is hyperkalemia. You will try to break the cycle. So you will give bicarb. Okay. So bicarb you will be giving to neutralize the hydrogen. Okay. And the result will be that the potassium level will decrease. This is another thing. Then now the potassium is killing the heart. So now you're giving heart some help. So that will be through calcium. Okay. So you are giving calcium gluconate or calcium chloride. Chloride is C is for C, so C match. So you can correlate them. They are more strong. Okay. So it has 3 times more ionized calcium. Okay, ionized calcium in calcium chloride. So if you need to give 1 ml of, for example, calcium chloride, you need to give 3 ml of calcium gluconate. So that's why calcium chloride is a better choice. Of course, these are details, but you will be giving calcium to strengthen the heart. Okay, now to kick them out of the body, the one of them is diuresis by furosemide, for example, or dialysis. Okay, so I hope you will never forget if you understand hyperkalemia in that way. In that way, you will never forget how to treat hyperkalemia. Okay, so some of the points with reference to treating hypotension I will do, and then we will finish our discussion for today. And tomorrow we will continue from here, because unfortunately I lost some tempo in the start and it lost time. Tomorrow we will try to move on from there and cover the rest of the vital signs and the complication which we say. But for today, we discussed about some of the arrhythmias. We discussed about the basic concept of airway breathing circulation, because if you understand this thing, the whole of the crisis management and emergency management will be around this thing. Okay, so dialysis will also remove the potassium out of the body. So this is, so whenever you are treating hypotension, as again going back to the same physiology, heart, you can give some inotrope to strengthen the heart. Inotrope, it will be a big topic, that what inotrope you can give according to the scenario, according to the situation. The inotrope will be either epinephrine, okay, either it is digoxin is also an inotrope. Then other medications like ephedrine, these are all working as inotrope. Ephedrine, so these are the medication which you will be giving to support the heart. Then the blood vessels, okay, so you see that the patient is vasodilated, so you need to increase the systemic vascular resistance, SVR. So you are giving vasopressor, what you call as vasopressors. Okay, so vasopressors either are pure alpha 1 agonist, because the receptors over there are alpha. In heart, there are beta 1 receptors. Okay, so beta and dopamine also, but mainly the in the heart, you, if you don't remember too many receptors, don't forget beta 1. So beta 1 and dopamine receptors are there in heart to increase the inotropy and increase the rate and contractility. Okay, when I'm telling heart, inotrope and also chronotrope, you can say. But chronotrope or hypotension is usually we don't use unless there is bradycardia. Chronotrope is to increase the heart rate, and inotrope is to increase the contractility. So usually to support the blood pressure, you are doing this. Phenylephrine is the pure alpha. Here there are main receptors are alpha 1. If you forget, except for the blood vessels of skeletal muscle. I repeat, except for the blood vessels of skeletal muscles, all the blood vessels of the viscera and everything has alpha 1 receptors. Okay, so you will be targeting alpha 1. So one of them will be phenylephrine and one of them will be norepinephrine. Okay, so norepinephrine has mainly alpha 1 agonist effect, but it has some miskin beta 1 also. So the difference will be that if you are giving only phenylephrine in a patient already having bradycardia, so it can aggravate bradycardia. How? Because it will cause reflex bradycardia further, because it is causing vasoconstriction. So whenever there is severe vasoconstriction, the reflex to the body to the heart is to cause bradycardia. So of course there is certain do's and don'ts about it. I'm just giving you a concept. So usually norepinephrine will not cause bradycardia. Okay, and then you are giving some fluid. Okay, if you want to support the circulation, I talked about heart, I talk about blood vessels. Now the fluid. So fluid started from crystalloids. Okay, so crystalloids may be normal saline. Okay, maybe ringer lactate, plasma light. Okay, usually these are isotonic fluids. You will be giving isotonic fluids. And the second thing is colloid. Colloids are either albumin, hesterol, okay, and gelafundin, gelafundin, and the one which is nobody uses dextrons. You can read in detail about all four of them. Usually the problems associated with them is an allergic reactions, coagulopathies. So you will be not using, but the advantage will be that they will be committed to their work. They will not go out. Crystalloids, they are crazy. They will not remain in the circulation after some time. Either they will be kicked out of the body through the kidneys, or they will go in the compartment. They are crazy people. They don't want to stay in their place of work. They are going in the third space. Okay, so only 1/3 will remain in the in the vascular in the vessels, and 1/3 will go out. Okay, So that's why the superiority of colloids and crystalloids, that colloids are committed people, they remain in the circulation for more time. And the third one will be the grandfather, blood and blood products. Okay. The blood products, there is no concept of blood transfusion now. There is concept of blood products. So you will be giving blood and blood products. So whenever you are handling hypotension, okay, your approach should be like this. Okay. So blood and products, this is, and again, a detailed topic, but the basic concept, what you should be knowing, what are the different blood products. So one of them is PRBC, one of them is FFPs, one of them is cryoprecipitates, okay, one of them is platelets. There is a concept now which is actually used more in other places than blood replacement, is platelet rich plasma. Platelet rich plasma, for the interest of the medical students. And even this topic they can ask you in the any exam. Remember, all hair transplant, they are injecting platelet rich plasma. Okay, because the after initial centrifugation, PRBCs are lost and the rest of the thing is platelet rich plasma. From there, they create FFPs and they pull out platelets. So this is the whole. So they are using in hair transplant because they have growth factors. They are using it in chronic joint pains. Okay. They are using it as skin, after skin grafting. And there's so many use of platelet rich plasma. You can read about it. So platelet rich plasma is the thing which can be asked in any exam, and all of you can read in details about it. Okay. So, and there are some artificial blood products, or you can say genetically engineered. So one of them is factor 8 concentrate. Okay. One of them is factor 7A concentrate. This is Novo 7, which is being used for coagulation problems. Okay. Because this is the grandfather of all coagulation. The new concept of coagulation says the cell-based theory, cell-based model or cell-based theory. And there are 4 steps in it: initiation, initiation, amplification, and propagation. Okay. So it is the one who initiate and amplificate. So if nothing is working with reference to control of bleeding, you have to go to Novo 7, factor 7A. And factor 8, usually they are giving for hemophilia. Okay. Hemophilia. Factor 8 concentrate or factor 9 concentrate is, or FFPs is also source of these things, because coagulation factors will be there. Cryoprecipitate mainly has factor 7, fibrinogen. So this is you also use in certain condition. There are a lot of diseases with reference to where these products are used: hemophilia A and hemophilia B, von Willebrand disease. So these are the things. And there are some other things which you are using for the bleeding. This is not our topic today, but I just give you a concept. So I hope you people understand the basic chunk of what my aim of discussion was for today. Okay. Any questions are welcome. And tomorrow, because unfortunately today I took more time in organizing the starting, I will request all of you to join tomorrow, same time, and we will continue and we will be faster than today. Okay. So our aim will be just like we started. So you will be going toward from heart rate to temperature. Okay. I'm just giving you what else is in my mind. So with reference to heart rate, a lot of things we have already covered, but unfortunately if new people come, and I will have to give you a summary of what we discussed today. So thank you all of you for joining. And the recording will be there on the YouTube channel after a few hours. And remember one thing: my aim is not to have any financial interest with this YouTube channel. Okay, this is all for you, and it's not a monetized channel. So we will be thinking about what happens in bradycardia, what happens in tachycardia. Temperature, very nice. Temperature management is, of course, either it is hypo or hyper. Okay. And there are a lot of problems related to hyperthermia, and there are a lot of problems related to hypothermia. So we will continue our discussion. And of course, because complications will be If you understand these things with reference to respiratory system, either it is apnea or tachypnea or decrease bradypnea, okay? Or there will be, in addition to respiratory rate, the problem will be with reference to dyspnea, the shortness of breath, okay? So there will be a lot of DD with this dyspnea, because dyspnea is related to either lungs, it may be related to heart, okay? And there are certain terrible complications which you have to rule out. One of them is pulmonary embolism, or there are certain other embolism which can occur, like fat embolism, air embolism, okay, and amniotic fluid embolism. So embolism is removing of anything which is blocking the vessels, okay? So when the right heart, which is receiving the blood, is blocked, the exit of the right heart will be blocked, nothing will be going towards the lungs. And if nothing is going towards the lungs, even the left heart will not receive anything. There will be no cardiac output, no life. Okay, so this is another thing. Then I'm just giving you an idea what is our focus. So these all three, the basic things will be the same. Then with reference to temperature, as I mentioned, one of the lethal complication which you can face in hospital is malignant hyperthermia. Okay, this is more related to use of inhalational agents or use of muscle relaxant, suxamethonium. But you should know about this malignant hyperthermia. Another form which you can face of malignant hyperthermia and is heat stroke. Okay, heat stroke. So you should be knowing why heat stroke occurs and what is the effect of high temperature. Similarly, if you think about hypothermia, so either hypothermia is resulting in, like, with reference to frostbite, okay, or any place where the patient is in hypothermia, there will be problems with reference to hypothermia. Then you will be surprised, there are certain conditions where you yourself create hypothermia. So this is called as deep hypothermic cardiac arrest. Okay, deep hypothermic cardiac arrest, which we create in cardiac surgeries, and you give what we say sustained hypothermia post cardiac arrest. Okay, post cardiac arrest to improve the neurological outcome. Post cardiac arrest, improvement of neurological outcome, you therapeutic hypothermia. Okay, targeted temperature control. Okay, so you are giving as a similarly, I'm just giving you an idea. I'm finishing in 1 or 2 minutes, inshallah. So another thing is that we discuss about hypotension in detail today, and there are some crazy periods when you yourself create hypotension. Okay, and you will be surprised that the miskeen anesthetist has to create the surgeon will be hitting with a big hammer in his hand. Doctor, maintain 60 millimeter of mercury mean arterial pressure. Okay, and they don't know why 60 millimeter of mercury is important, and we have to create hypotension. This is called as therapeutic hypotension, or you can say allowable hypotension, or you can say, like, in certain conditions, what is called as hypotensive anesthesia. Okay, and the basic concept of hypotensive anesthesia or creating therapeutic hypotension is that to prevent the bleeding. Okay, to prevent the bleeding. But a lot of problems can occur if you are giving this hypotensive anesthesia or sustained hypotension without any understanding. Okay, because sustained hypotension, what will occur? Why hypotension is important? Because hypotension, what will affect the oxygen delivery. Okay, ultimately, if oxygen is not delivered because of poor circulation, poor perfusion, the problem will be there. Okay, and the vital organs, why this word, can anyone tell why this 60 millimeter is the lower limit for hypertension for which we are giving? Because the brain circulation is maintained between 60 to 160 millimeter of mercury of mean arterial pressure. They will maintain the circulation, maintain the requirement of the oxygenation, at this. But so if the mean blood pressure goes below 60 millimeter of mercury, the brain will not be able to maintain. So this is the reason. But if you think about heart, sorry, kidneys, it's 80 to 180 millimeter of mercury. That is the reason if there is sustained hypotension, maybe the patient does not die, heart will not have any problem, brain will not have any problem, but there is AKI, acute kidney injury, and there is no urine output. The reason is that maybe the blood pressure is good enough to maintain the life, but kidneys get angry. They said, I want higher pressure. So the perfusion pressure for kidneys is 80, not 60. Okay. So the renal perfusion pressure should be maintained. So this is the concept. Another concept you should be understanding the perfusion pressure of all the vital organs, the brain, the heart, the kidneys. Okay. These are the major organs. Then what else will be occurring with hypotension? With reference to intestine, what will happen? There will be mesenteric ischemia. Mesenteric ischemia. Okay. I know that if the medical students are listening, this will be a slightly difficult, but believe me, it's very simple. So intestines, if they are not having there is hypotension, and actually another problem. Whatever medications usually we are giving, they are alpha 1 agonists, the vasopressors. They are damaging the mesenteric or visceral blood flow. Okay. Visceral blood flow, kidneys. Okay. So they are affecting badly. So it will cause mesenteric ischemia. And how you can pick? One of them is lactate level. Okay. So any sign of poor perfusion, the lactate will going high up. And this is a sign of anaerobic circulation. Okay. Anaerobic circulation. So now it means that the perfusion of the body is not maintaining the oxygenation, and body is trying to have anaerobic sources of creating the ATPs. Okay. So the lactate level will be going high up. So this will be a sign of mesenteric ischemia. So kidneys, I told you, intestines, I told you, brain, I told you, and usually what will happen if there is, you are using big doses of vasopressors for a prolonged time in the ICU, especially, or even in emergency, there will be digital ischemia, not the IT digital of the internet, the digits. Okay, the fingers, the peripheries. You will have gangrenes because there is peripheral vasoconstriction. There is no blood going to the skin in a nice way, and actually it is causing the digital ischemia and even gangrenes. Okay, so some of the problems will be because of the main pathology, and some of the problem will be the result of the treatment. So you are giving any vasopressors, these problems can occur. If you are giving any medications to increase the heart rate or increase the contractility, now arrhythmias can occur. Okay. So if you have given volume, okay, and the body is not able to control that volume, okay, then patient can go in overload. Though the patient is having hypertension, but patient still can go in overload. Patient can still go in overload. So you have to maintain the signs of overload. So signs of overload will be, you will be auscultating the patient, and there will be crepitations. Okay. Then this is one thing. What else? Signs of overload. If you have echo, you can put in the epigastrium to see the IVC. IVC compressibility. Okay. If IVC is compressible, it means patient needs more fluid. If IVC is not compressible, distended, and you are giving more and more fluid, patient can go in overload. Okay. If you don't have echo, but still you can do this very important test is leg raising test. Leg raising test. Okay. If you raise the foot side of the patient, and the blood pressure improves, okay, or heart rate improves, or if you are having cardiac output monitor, okay, if you are using cardiac output monitor, there is a concept of stroke volume variation. Okay. the more hypovolemia, the more stroke volume variation. I repeat, the more hypovolemia, the more stroke volume variation. So if there is a more stroke volume variation, and with this leg raising test or a fluid challenge or this IV compressibility, all these things you can get about this thing. Of course, other things will also be coming, that you will have a patient at risk. Okay. So whenever you are treating hypotension, so I'm finishing my talk now. Remember one thing, hypotension or any vital change in vital sign is a tip of iceberg. If you want to be a good clinician, whether you are a consultant, whether you are dealing in emergency, you should be looking overall at the patient, not only one thing. Okay. Maybe the patient is hypotensive, the reason is only low blood sugar. Okay. So don't miss these things. This will be actually coming in the D. All the things which are not in ABC will be in the D. You will be looking at all other causes of hypotension. Okay. So that may be low blood sugar, and the vital organs like pulmonary causes, neurological causes, cardiac causes. Okay. So you should be knowing all, of course, renal and liver also, but usually these are the three things which will be there. So you will be ruling out any stroke, TIA, maybe hypotension, any arrhythmias, ischemia, infarction, hypotension. The lungs are not good. It can cause patient is in pulmonary edema, patient is overloaded, patient is not having good saturation, not oxygenating well. It can also result in hypotension. So I hope I gave you a conceptual ideas about how you should be dealing any patient in the emergency, whether you are in ICU, whether you are in operation theater. I think some of the medical student also listened. So share the message. If you have the good concepts, you can deal any situation, any exam. Okay. So thank you very much, and we will continue from here tomorrow. Bye bye.